We are going to discuss ameloblastic fibroma, another odontogenic tumor, but which is derived from both epithelial and ectomesenchymal components and hence a mixed odontogenic tumor. Ameloblastic fibromas are rare tumors. They constitute only approximately 2% of odontogenic tumors. They are mixed tumors, meaning thereby there is both proliferation of odontogenic epithelium and mesenchymal tissue. So, the two components which are seen are epithelium and mesenchymal tissue. These both components are neoplastic components. Important thing about ameloblastic fibroma is generally there is no formation of enamel or dentin. So there is no hard tissue formation. That is why it is also called as mixed odontogenic tumor. It is believed to be less aggressive than ameloblastoma. It is seen in younger age, usually between 10 to 20 years. Average age of occurrence is 15.9 years and male to female ratio is 1.26 is to 1. Ameloblastic fibroma is seen in mandible in approximately 75% of the cases. Maximum of these occur in mandibular region. Ameloblastic fibroma is asymptomatic and the initial clinical presentation often swelling which is very slow. These are diagnosed on routine radiographic examination and then by histopathology. The patient is younger in age, so found in association with unerupted or displaced teeth. The radiographic features resemble that of dentigerous cyst. So, dentigerous cyst is very important differential diagnosis radiographically. The borders are generally well defined and these borders are sclerotic. The radiolucency in most of the cases is unilocular. Very often it is not multilocular but can be honeycomb appearance. Histopathologically, the strands of cells are seen. These strands are basically two rows of epithelium. These rows of epithelium are bordered by tall columnar cells. Sometimes also the islands are seen which consist of peripheral columnar epithelial cells. So the resemblance can be with that of ameloblastoma. These islands have got central loose stellate reticulum like cells. But there is presence of mesenchymal component. The mesenchymal component here is neoplastic. Doesn't resemble the ectomesenchymal component of ameloblastoma. What is the difference here? The mesenchymal component in case of ameloblastic fibroma resembles that of dental papilla. doesn't contain mature collagen bundles, and there is absence of fibroblasts. Ameloblastic fibromas, they can occur on peripheral areas of jawbone, and these can occur in soft tissues. But peripheral ameloblastic fibromas are very, very rare. Even if they are present, they are diagnosed on basis of histopathology, and they often resemble other soft tissue lesions like fibroma or peripheral giant cell fibromas. The treatment of ameloblastic fibroma is surgical removal. Earlier, simple surgical excision was advocated because it was believed that there are less chances of recurrence. So, the treatment is by more aggressive surgical therapy with a long-term clinical follow-up. The recurrence rate is higher than originally suspected. Recent studies indicate recurrence rate as high as 33.3%, but many of the studies indicate less recurrence rate. It can transform in ameloblastic fibrosarcoma. Again, it is very rare, and the final diagnosis is by histopathological examination. If there is dentin or enamel formation, the lesion is classified as ameloblastic fibrodentinoma or ameloblastic fibroodontoma, respectively. Many studies indicate they are separate tumors because the age range is slightly lesser than ameloblastic fibroma. Again, these tumors require long-term follow-up because there can be chances of recurrence. The differential diagnosis of ameloblastic fibroma is number one, ameloblastoma, but ameloblastoma do not contain dental lamina like strands, and stroma is collagenous fibrous tissue rather than loose fibrous tissue or dental papilla like tissue. Second important differential diagnosis is dentigerous cyst, and calcifying odontogenic cyst is also considered, but it is very, very rare. To conclude, there are both neoplastic, epithelial, and ectomesenchymal components. There is no dental hard tissue formation in ameloblastic fibroma, no in second decade of life, common in posterior mandibular region. There are chances of recurrence and so needs long-term follow-up. Thank you.